AETCM, the emergency medicine channel. Myself, Dr. CECIL Maria. I am presenting today metabolic acidosis types and explaining about lactic acidosis as a part of EM Rapid 2024. We all know about the equation that carbon dioxide plus water will give rise to carbonic acid in the presence of carbonic anhydrase, which will again break up to H plus and bicarbonate. This equation shows the main buffering system of our body. So, what is metabolic acidosis? Metabolic acidosis is defined as the process in which the body contains excess of acid, which may be due to increase in acid production or due to a decreased bicarbonate concentration. It can be due to, it is defined as a low arterial pH, that is pH is less than 7.35, which results either from a metabolic component or from a respiratory component or both. Coming to pathogenesis, it is maybe due to increased acid generation and loss of bicarbonate and diminished renal acid excretion. The types are normal anion gap metabolic acidosis and high anion gap metabolic acidosis. We will come to that, this anion gap. So, first one is increased acid generation. What are the causes? It can be due to lactic acidosis, that is an increase in acid production in our body. It is either due to lactic acidosis, diabetic ketoacidosis is mainly due to increased sugars, or ketoacidosis can also be due to increased alcohol intake and also due to fasting. And ingestions or infusions of these acids like methanol, ethylene glycol, diethylene glycol or propylene glycol, aspirin poisoning, chronic acetaminophen poisoning, and then D-lactic acid generated by carbohydrates of GI bacteria, then toluene. Then the loss of bicarbonate, it may be due to severe diarrhea and in some ureteral implantation into sigmoid colon or creation of a replacement urinary bladder using segment of GI tract, the urine will be exposed to the GI mucosa, which causes the loss of bicarbonate. And proximal or type 2 renal tubular acidosis, in which proximal bicarbonate reabsorption is impaired. Then diminished renal acid excretion. It is reduced excretion that occurs in conjunction with a reduction of GFR, that is mainly kidney impairment, and distal or type 1 renal tubular acidosis and type 4 renal tubular acidosis, in which tubular function is a primary problem and glomerular filtration is initially preserved. So, what is anion gap? Anion gap, it is the difference between the primary measured cation, that is sodium, and the primary measured anions, chloride and bicarbonate. In order to maintain the electrical neutrality of the body, the sum of all anions should be equal to sum of all cations. That is, sodium is a primary measured cation plus all unmeasured cations should be equal to chloride plus bicarbonate and all unmeasured anions. So, we will rearrange the equation, which causes sodium minus chloride plus bicarbonate will be equal to all unmeasured anions minus all unmeasured cations, and this is that is all unmeasured anions and all unmeasured cations is the serum anion gap. So, serum anion gap is equal to sodium minus chloride plus bicarbonate. The normal range is 8 to 12 milliequivalents per liter. In a normal individual, the major unmeasured anion which is responsible for the existence of anion gap is albumin. So, according to this anion gap, the metabolic acidosis can be divided into high anion gap metabolic acidosis and normal anion gap metabolic acidosis. It is NAGMA and HAGMA. So, what is HAGMA? That is high anion gap metabolic acidosis. When a strong acid other than HCl is accumulated, the bicarbonate concentration falls. So, the chloride concentration and other unmeasured anion remains relatively unchanged and only the acid anion increases. Thus, there will be increase in anion gap. So, the causes of HAGMA, as we all studied, it is mud piles, that is methanol, uremia, DKA, propylene glycol, INH or iron, lactic acidosis, ethylene glycol, salicylates. What is NAGMA? Normal anion gap or hyperchloremic metabolic acidosis is caused by loss of bicarbonate or a disorder that reduces the renal acid excretion in relatively normal GFR, that is type 1, 3, 4 renal tubular acidosis. When hydrogen chloride is added to extracellular fluid space, bicarbonate is replaced on an equimolar basis by chloride. Thus, there will be no change in serum anion gap. The causes of NAGMA are diarrhea, prolonged exposure of urine to colonic or ileal mucosa, as we said earlier, during the ureteric implantation, and proximal or type 2 renal tubular acidosis. So, coming to the major causes of the metabolic acidosis, the mechanism and either the high anion gap and normal anion gap. First one is increased acid production. Increased acid production mostly will be the increased anion gap, that is HAGMA causes. Lactic acidosis, ketoacidosis, it can be due to diabetic, alcohol intake and starvation, and ingestions of the acids and alcohols. In that toluene, if early or if kidney function is impaired, it may cause HAGMA, and if it is latent, if the kidney function is preserved, it will cause NAGMA. Second one is loss of bicarbonate or bicarbonate precursors. It will mainly cause NAGMA, that is diarrhea or other intestinal losses, type 2 or proximal renal tubular acidosis, post treatment of ketoacidosis, carbonic anhydrase inhibitors and ureteral diversions. Then third one is decreased renal acid excretion. It may be the HAGMA, in the HAGMA causes it is a severe kidney dysfunction, that is the eGFR is less than 15 to 20, and moderate kidney dysfunction, that is more than 15 to 20 will be eGFR more than 15 to 20 ml per minute per 1.73 meter square will be NAGMA. Type 1, type 4 RTA will be in this, hyperkalemic RTA and voltage defects, and large volume infusions of normal saline can cause NAGMA. Coming to delta anion gap and delta bicarbonate ratio. The serum anion gap is elevated in such metabolic acidosis where a strong acid other than HCl is added, that is, as we said, lactic acidosis and ketoacidosis. So, the addition of such an acid, that is the lactic acid, to extracellular fluid may cause the following equation, that is lactic acid plus sodium bicarbonate will cause sodium lactate carbonic acid, which may again break down to sodium lactate carbon dioxide and water. So, if you are thinking that our extracellular space is an isolated component and only the sodium bicarbonate is the only buffering salt in that space, and none of the lactate or hydrogen ions are lost through the urine, there is then the serum increase in serum lactate concentration and increase in serum anion gap would exactly match the decrease in serum bicarbonate caused by the buffering of hydrogen ions. These opposite changes in serum anion gap and bicarbonate concentration would result at delta anion gap by delta bicarbonate ratio of 1:1. So, interpretation of that delta anion gap by delta bicarbonate ratio, if it is less than 1, it may be there will be a coexisting normal anion gap metabolic acidosis or a HAGMA in which both kidney function is preserved and the acid anion is readily excreted into urine like DKA, toluene ingestion and D-lactic acidosis, or early kidney function impairment in which type 4 renal tubular acidosis has developed as a result of impaired renal tubule excretion that is more severe than the impairment in acid anion excretion. If it is the ratio is equal to 1, it is uncomplicated HAGMA, and if it is between 1 to 2, it may be lactic acidosis and metabolic alkalosis which coexisting with the HAGMA, and if it is more than 2, it will be a metabolic alkalosis coexisting with a high anion gap metabolic acidosis. So, how to evaluate a metabolic acidosis? Initially, first we have to find out the arterial pH. Look in ABG the pH of the blood. If it is look whether it is less than 7.35, and so if it is acidosis. So, if we want to know the next thing we want to know is either it is metabolic or respiratory. So, look at the bicarbonate and carbon dioxide. If bicarbonate is low, it is metabolic acidosis. If carbon dioxide is high, it is respiratory acidosis. And calculate the anion gap, that is by the equation sodium minus bicarbonate plus chloride. If it is more than 12, it is HAGMA. If it is unchanged or normal, it is NAGMA. And look whether the ventilatory response is as expected. It is by Winder's formula. Winder's formula is PCO2 is equal to 1.5 into bicarbonate plus 8 plus or minus 2. So, if measured PCO2 from ABG is equal to expected PCO2 value, then there is an appropriate respiratory compensation. If it is more than the expected value, there is a concomitant respiratory acidosis. If it is less than the expected value, there will be a concomitant primary respiratory alkalosis. Coming to lactic acidosis. Lactic acidosis, if the lactate levels are more than 2 millimole per liter, it is hyperlactemia. To tell it is lactic acidosis, it should be more than 4 millimole per liter. So, coming to the pathophysiology of lactic acidosis, first one is increased lactate production. That is the increased lactate production is caused by first one, increased pyruvate production. So, the enzymatic defects in glycogenolysis or gluconeogenesis, respiratory alkalosis, pheochromocytoma, beta agonist, sepsis, it all cause increased pyruvate production, which in turn increase lactic acid production. Then reduced entry of pyruvate into mitochondria. It may be congenital and also seen in diabetes and Reye syndrome. Then if there is a shift of cellular cytoplasmic redox state such as NADH accumulates and NAD plus falls, there will be it will drive the pyruvate lactate ratio towards the lactate. It may be caused by enhanced metabolic rate, that is grand mal seizures, severe exercise, hypothermic shivering, severe asthma, and decreased oxygen delivery such as seen in shock, cardiac arrest, pulmonary edema, carbon monoxide poisoning, severe hypoxemia, pheochromocytoma, and reduced oxygen utilization, which is seen in cyanide intoxication, drug induced mitochondrial dysfunction due to zidovudine or stavudine, and also in sepsis. Then if there is a primary decrease in lactate utilization, it is mainly hypoperfusion because the lactate cannot be utilized, and then alcoholism and liver disease as we commonly seen in CLD patients. Then mechanisms which cause lactic acid, which is uncertain mechanisms. It is like malignancy, diabetes mellitus, acquired immunodeficiency syndromes, hypoglycemia, and idiopathic causes. Clinical causes, there are two types, type A lactic acidosis and type B lactic acidosis. Type A lactic acidosis, it is mainly due to marked hypoperfusion, which is caused by hypovolemia, cardiac failure, sepsis, or cardiopulmonary arrest. And type B lactic acidosis, where the hypotension is not that much apparent. So, the mechanism will be toxin induced impairment of cellular metabolism and regional areas of ischemia. The mechanisms are, first one is diabetes, biguanide therapy with metformin, and biguanide therapy in patients with reduced kidney functions also we can see type B lactic acidosis. And the second one is malignancy in leukemia, lymphoma, or other solid organs malignancies. Alcoholism, because in this alcoholism the lactate utilization will be reduced, and toxic alcohols. HIV infections, it may be sepsis induced lactic acidosis and also antiretroviral induced mitochondrial dysfunction, and beta adrenergic agonist, that is IV epinephrine. It will cause increased glycolysis in skeletal muscles and hypoperfusion of the GI tract, and it causes lactic acidosis. Then mitochondrial dysfunction, that is inherited disorders, thiamine deficiencies, drug induced, that is antiretroviral drugs induced, high doses of propofol and linezolid also can cause lactic acidosis. Coming to bicarbonate therapy, it is only 2 to 3 indications are there in metabolic acidosis for the bicarbonate therapy. First one is very low bicarbonate levels, which is less than 4 milliequivalent, and severe acidemia, pH less than 7 to 7.15, and severe hyperchloremic acidemia. The goal of bicarbonate therapy is to restore the buffer. The buffer in our body should be restored. That is, the bicarbonate should be more than 8 milliequivalent per liter, or to achieve clinical improvement in shock or dysrhythmia. 75 ml of 8.4% sodium bicarbonate in 500 ml dextrose 5% in water is nearly isotonic solution for infusion, and it is used. So, this is all about the metabolic acidosis and mainly about lactic acidosis. Thank you.